Hello and welcome to another video. Today we're going to be talking about breast cancer. So how does this typically present clinically and everything you need to know about the clinical signs as well as investigations we'll carry out and management for breast cancer. And then I'll end with covering the types of breast cancer that exist, the invasive forms and the epithelial forms. So when it comes to breast cancer, it presents as a firm, painless, irregular mass, commonly in the upper outer quadrant close to the axilla, and it may also increase in size. Now, what's important here is that the way that breast cancer, which would be malignant, increases in size is non-cyclically, but we know that in fibrocystic disease, there can be a lump which can increase in size cyclically along the time of the menstrual cycle. So it's very important to remember that pain is non-cyclic in nature when it comes to breast cancer. So what are a few of our signs? So there can be lumps which are present. There can be nipple discharge. There can be dimpling and skin retraction, as well as nipple retraction or inversion, redness, and even a peau d'orange sign, which I'll show you in a bit. There can be changes to the skin's texture, as well as pain and lymph node changes and swelling. Now, you can remember some of these signs with the mnemonic LMNOP. So L is for any lump, so you want to, as a doctor, inspect and palpate for any lump or a mass. Then M for any mammary changes. Well, this kind of means any changes on the surface of the skin, dimpling, tenderness, and abnormal contours. There can also be nipple changes, which can be what kind of changes? You can get retractions, you can get lesions, and you can obviously get discharge as well. Now, your other symptoms, L for lumps, M for mammary changes, N for nipple changes, O for other, and P for patient risk factor. So where does breast cancer typically occur? It occurs in the upper outer quadrant, so in this region. What are the risk factors for breast cancer? So here's our mnemonic, which is NEMO, which stands for nulliparity, which is never having any children. Early menarche, which is when females experience their menstrual cycle at an earlier age. Menopause happening late, obesity, never breastfeeding. What you'll notice is these risk factors all have one thing in common, which is increased estrogen exposure. And increased estrogen exposure throughout a woman's lifetime may happen in all of these conditions, because remember, nulliparity, when women go through pregnancy, each pregnancy increases progesterone and the hormonal effects of estrogen are minimized. Therefore, having more kids and therefore having these hormonal changes is actually a protective. So having more pregnancies is a protective factor when it comes to breast cancer. This peau d'orange appearance is like an orange skin appearance. It's orange and there's speckles which make it appear like an orange basically, and that is a sign of lymphatic obstruction or lymphatic changes actually. So breast cancer screening occurs in the UK and it's usually there to reduce morbidity and mortality, and it actually involves a 3-year mammogram, which is an X-ray, which is often how we detect these breast cancers. And on mammogram, often you will find microcalcifications, which are very common for breast cancer. And this 3-year screening program occurs for all women between the ages of 50 and 70. Then you also have certain risk factors like genetics. Now, if you have an increased BRCA1 incidence and BRCA2, these are genes. These are genes, and you have increased expression of BRCA1 or BRCA2. When it comes to BRCA1, BRCA1, this increases your risk for both breast and ovarian cancer. So that's why this is a mnemonic I found from another video, 1 times 2, because it increases the risk of 2 different types of cancers. Then you have BRCA2, which increases breast cancer risk in males. It's breast cancer only, and it increases the risk in males and females. But for this one, the mnemonic would be man to man, which is why BRCA1 increases the risk of it in males. There's also specific hormone receptors for which breast cancer can be positive, such as estrogen, progesterone, and HER2 receptors. What investigations are we likely to do in a patient suspected of breast cancer? Well, women are often screened every 3 years, as I already mentioned, but the diagnosis of breast cancer is by triple assessment. That means you do 3 different types of assessments, which is the clinical exam, examining the patient physically, and imaging, which would often be mammography, mammogram, and cytology, which would be to check for the cells that are present. Are they malignant? Are they benign? Have they invaded the basement membrane? Remember, you have different epithelial cells, and as long as they don't yet invade the basement membrane, that would be known as carcinoma in situ. But as soon as they start to invade the basement membrane and go further down, that's when these cancerous cells become invasive. And that's what is known as invasive carcinoma, rather than just ductal carcinoma. So what kind of mammography suspicions should we be looking out for? You might want to look out for an irregular mass seen on mammography and microcalcifications as well. Okay? Also, yes, okay. Now, we also want to talk about what makes these breast cancers so receptive to hormonal treatment. Well, what makes them so receptive to hormonal treatment is having steroidal receptors. Remember, these steroidal receptors on their cell surface or on their nucleus especially, are sensitive to hormones. That means that these cancer malignant cells, neoplastic cells, have hormonal dependence. That's why we use hormone treatments. Also, what does the prognosis of the breast cancer depend on? So the prognosis often depends on axillary lymph node involvement, and for that we can do a sentinel lymph node biopsy, those kinds of things. Having hormone, so a poor prognosis is with an axillary lymph node involvement. That is a poor prognosis. So is having hormone negative cells, so cells which are not estrogen positive, so they're estrogen negative, progesterone negative, or HER2 negative. They have overall prognosis. Why? Because we can't target them with hormonal therapy. Now, my management for all oncological conditions can be remembered with this mnemonic chart. C for chemotherapy, H for hormone therapy, A for adjuvant, R for radiotherapy, and T for targeted therapy. So you can use all these forms of therapy. But surgery is obviously the definitive treatment, and a lumpectomy is just excising the lump on the breast, whereas a mastectomy is excising the whole entire breast. Now, it can be a simple or total mastectomy. When do we start to dissect away the lymph nodes? If you have invasive breast cancer, the surgeon will sometimes recommend removing the lymph nodes in the armpit. That's known as axillary lymph node dissection, and it's often done when there are malignant cells in the fine needle aspiration, FNA, or biopsy of the lymph nodes. Remember, here are your lymph nodes. Here is a presenting tumor. Here you insert a radioactive substance or a dye and watch the flow of this radioactive substance through the lymph nodes. And if you find that there's a tumor, and then you can excise some of that. For example, this is a probe, here's the sentinel nodes, and you can take out the tumor and the sentinel nodes. That is as long as this tumor has not yet spread. If it's spread to this, so the basis of a sentinel lymph node biopsy is that the tumor has not yet drained to the rest of the lymph nodes. Therefore, we excise the first lymph node close to the tumor to prevent not to the nipple, close to the tumor, to prevent any of the malignancy from spreading, any of the cancer from draining into further lymph nodes. So what is the stepwise management of breast cancer? You want to stage the breast cancer. The staging is depending on tumor, node, and metastasis. Then you want to do a surgery. You can do a breast conserving surgery, which is preferred, or a total mastectomy. And immediate reconstruction options are also discussed. Further investigation would be a sentinel lymph node biopsy. You want to do an axillary staging. Remember, axillary lymph node metastasis was a prognostic factor, especially a poor prognostic factor. So in the case that you want to do a pre-surgical axillary staging, pre-surgical, how? By doing an ultrasound and a sentinel lymph node biopsy. When you do the sentinel lymph node biopsy, you would then take it out with a probe, and then once you've taken that lymph node out, you would then check do the biopsy there. Okay, if suspicions are present, do you undergo what kind of investigations can you do for metastatic disease, X-ray, CT scans, bone scans? Breast cancer can actually metastasize to a lot of places. So it can metastasize to the bone, metastasize to the lung, can metastasize to the brain, So be aware and do all your checks. What about your adjuvant therapy? When is radiotherapy considered? Radiotherapy is considered an early invasive cancer if there's a high risk of recurrence and if you can't actually take out the axillary lymph nodes. And it's also done post-ductal carcinoma in situ. Chemotherapy is indicated in sentinel involvement. So once you start to involve, so if this is the breast and here was the mass and this lymph node is involved, you want to go on and give that patient chemo because you don't want it to spread. Okay, you can use adriamycin, cyclophosphamide methotrexate, and 5-fluorouracil. And finally, endocrine therapy, which is hormonal therapy, can be used in patients with receptor-positive tumors. What is a receptor-positive tumor? It is one which is receptive to the HER2, which is positive for HER2 or estrogen. For HER2, you would specifically use trastuzumab. Remember, you trust trastuzumab, because you trust her, which is a monoclonal antibody. And for estrogen positive, you can use both tamoxifen and raloxifene and aromatase inhibitors. How does this treatment or management strategy change based on how far the disease has progressed? Well, if it's a localized disease, you really just want to conserve the breast, do a lumpectomy or something like that, conserve the breast, and then continue on with a radiotherapy and sentinel lymph node biopsy. But this is not routinely done. Usually you do surgery, but only in the metastatic case you will not do surgery because it's too late, it's already metastasized. You're going to give supportive or palliative therapy. Now you have your early invasive versus locally advanced. Early invasive surgery and axillary staging. Remember, axillary staging was so crucial. Locally advanced, you already know it's spread. Now you want to give radiotherapy. Radiotherapy is actually to cause apoptosis and destruction of those malignant cells. Plus, you continue on with systemic therapy. Prognostic factors don't just include axillary lymph node involvement, but it also includes the tumor size, the type of the tumor, the grade of the tumor, is there metastasis, is there vascular or lymphatic invasion, is there a specific lymph node status, and complications include lymphedema. We have covered it very thoroughly, but now let's move on to the specific types. before we move on to these 6 specific types of breast cancer, it's important to understand one thing. So the breast cytology or the histology. So the way it is really is that you have, let's do this. Here is the normal lumen of the breast, okay? And the breast ducts and the lumens, and how exactly you'll see the lobules and the ducts. But essentially, what happens is that you have these, here, if this was the lumen, around the lumen, you have these luminal epithelial cells. These are your luminal epithelial cells. I like to remember them as Louis. So these are your luminal epithelial cells because they are towards the lumen of the breast. Then you have, after that, let me do this in a different color. You have your myoepithelial cells. So just like your luminal epithelial cells and your myo. So your luminal epithelial cells are influenced by prolactin, whereas your myoepithelial cells are influenced, so these were your myoepithelial cells. Your luminal cells are responsible for production of milk. That's why they are also under the influence of prolactin. Your myoepithelial cells are responsible for the contraction and, really pushing that milk out. And that's your myoepithelial cells that I've drawn here. Okay, these are under the influence of oxytocin. Now, the way that you can get in malignant breast cancer is basically you have atypical luminal epithelial cells. So as your atypical Louis, as your atypical Louis rise, that is going to cause increased risk for malignancy. Okay? And here, by the way, is your basement membrane. Here and here would be your basement membrane. Okay, now, in simply your ductal carcinoma in situ and your invasive ductal carcinoma, in both of these, both have atypical Louis. They both have atypical luminal epithelial cells. The difference is which of these has invaded the basement membrane. This one, in ductal carcinoma, it's not yet invaded the basement membrane. And invasive ductal carcinoma, it has indeed invaded the basement membrane. Okay. And as soon as it invades the basement membrane, it's also going to cause cancer cells to invade and proliferate. One more thing just to realize, what are the differences between the ducts and the lobules? So these are your lobules. These are your lobules, and this is your duct in the breast. And here is another lobule, and here is a duct. So this is a lobule, and this is a duct. And basically,